So happy New Year, firstly, everyone, and welcome to today's Grand Rounds. So it's my pleasure today to kick off the first Grand Rounds of the year. Just a few housekeeping issues. If you wish to submit your questions, do so via the Q&A feature, not chat, and they'll be answered at the end of the presentation. We will also be accepting live questions at the end of the presentation, and for that, please use the hand up feature, and you'll be asked to unmute by the moderator visually. And then use the feature if you're experiencing any technical difficulties in the meantime. So today we have the pleasure of Dr. Sanjit Jolly, who will talk to us about recent trials in interventional cardiology, and in particular, the CLEAR OASIS 9 trial, which we are part of. So I would have thought that Dr. Jolly wouldn't have needed any introduction in the Canadian landscape, but nonetheless, it's a formality. So he's an interventional cardiologist in the Hamilton Health Services. He's a professor at McMaster University, and he has been, at the forefront of all research in terms of interventional in Canada and worldwide. So he's had formal training in the clinical trials in health research methodology from McMaster University. He was the principal investigator for the RIVAL trial, a randomized trial of over 7,000 patients comparing radial and femoral access for coronary intervention. He's also the principal investigator of the recently completed TOTAL trial, an interventional randomized trial of over 10,000 patients of thrombectomy during primary PCI, which was standard up until a few years ago. He's currently the principal investigator of the CLEAR OASIS 9 trial that is examining colchicine and spironolactone in acute myocardial infarction with a number needed to recruit of 7,000 patients. In total, he's obtained more than $30 million in funding between industry and peer-reviewed grants. Without taking much further time, I'll hand the floor to Sanjit.
Okay, thank you, An Young. It's my pleasure to be there in spirit and be here virtually. I had hoped that we'd be past this and I'd be able to do this in person, but I think we're all in this boat together. So I'm going to talk about recent interventional trials from the Population Health Research Institute at McMaster and describe the rationale of why we're doing the CLEAR OASIS 9 trial. These are my disclosures. So in terms of recent PHRI trials, I've cherry-picked a little bit. We're going to talk about a relatively small trial looking at radiation safety in the cath lab, which I think is probably important for anybody who works either in EP or X-ray in terms of radiation exposure. We're going to talk about the TOTAL trial, the thrombus aspiration with some cases. We're going to talk about the recently completed COMPLETE trial, looking at complete revascularizations and STEMI, and then finally talk about the rationale and design of the CLEAR Synergy OASIS 9 trial. So why is radiation important? And this is an image of a glioblastoma multiforme in the brain. And of course, we all know that this is a terrible diagnosis and nearly universally lethal. And this is important because there has been a number of case reports of brain tumors in interventional cardiologists. In fact, 36 cases. This was published in Neurointervention. In fact, there was a clustering in Toronto, I remember during my training. In this case series, half were glioblastoma multiforme, and the vast majority were left temporal. And why is that important? As an interventional cardiologist, most of your radiation exposure is on the left side of your brain. So left temporal would make sense if it's radiation exposure. There was a mean of 23 years in practice, so cumulative exposure. And there is some data suggesting that interventional radiologists, have a 600% increase in brain tumors, but you have to remember that if the baseline incidence is very, very low, a 600% increase is still very, very low. So the interventional fellows shouldn't quit their fellowship just yet. We did a randomized trial where we tested two interventions. One was a non-lead cap. This is the RadPad no-brainer cap. It's a non-lead product that is actually almost as light as a paper cap that you can wear. And we had dosimeters inside and outside of this cap. And we randomized patients to a pelvic lead drape, essentially just a piece of lead over the belly. This was the design. We randomized 230 patients. And this was an example of a fellow-led randomized trial. One of our interventional fellows designed the trial, wrote the protocol, wrote the case report forms, obtained a small grant, and then published it in Circ Interventions, which was fantastic. And so patients were randomized to pelvic shield versus no pelvic shield, and the interventional cardiologist wore this radiation cap with dosimeters inside and out. And what we showed was that we were able to reduce operator radiation exposure by 76% by the simple intervention of just putting a pelvic lead drape over the patient's belly. And this is really, really impressive. And when I say to the interventional fellows, what we found was that essentially putting lead over the belly converted a complex 3-hour CTO PCI to a diagnostic cath. So in terms of protection, it's very simple and very effective. Wearing the cap appeared to reduce radiation exposure by about 81%. The caveat, of course, is that you're not wearing the cap over your ears. It doesn't come down over your chin. So it does only protect a small portion of the head. You're still getting a lot of radiation from below. So, it's interesting when I present the radiation protect study, a lot of individuals who are not using lead drapes on their patients say, in fact, this is one of the most insightful studies. And I often get emails and phone calls afterwards asking for our setup in terms of how we do this. And in fact, what we've gone to is, sometimes we don't even prep the femorals for outpatients to allow easier use of the lead drape. So the next question was thrombus aspiration in STEMI. And, this seemed to be a no-brainer. So on the left-hand panel is a STEMI where you have distal embolization of thrombus. You have a stent open, but the clot has gone downstream. And you really have not a very good result. And we know the outcome of these patients are poor when they have poor reflow after a stent deployment. And on the right-hand panel is a cast of thrombus that was removed by a manual aspiration device, and it simply made sense. Remove the thrombus before you put the stent, and you can prevent this complication and you can save lives. And I remember as a young interventionalist back in 2008, sitting in the audience, I think at ACC, the TOPAZ trial, which randomized just over 1,000 patients, showed a modest improvement in a surrogate outcome. That's angiographic myocardial blush grade 0-1. So essentially a form of myocardial perfusion based on angiogram. And this modest improvement led to a 50% reduction in mortality. And I went home thinking, I need to use thrombus aspiration in every case. I was excited. And the very next day after I arrived back, I got an opportunity. This is a 52-year-old male, inferior STEMI, had a prior stent to the circumflex about a month prior, and was on aspirin and clopidogrel. This was in the pre-ticagrelor era. And so we reloaded with clopidogrel, aspirin, IV heparin, and I'll show you the angiogram here. You can see you have an acute occlusion within this prior stent with a large amount of thrombus. We wired it, and there was a large cast of thrombus there. And I said, you know what, I'm going to save this patient's life. I'm going to do thrombectomy. And we were pretty excited. And I performed thrombectomy. We made multiple passes. And then the next picture I took is here. And what you see a large filling defect in the left main. The circumflex looks a lot better, but the thrombus was so large that it likely sheared off the end of the export catheter and into the left main. This is a 52-year-old gentleman who we've converted a circumflex occlusion into a potentially left main occlusion. He started getting hypotensive, diffuse ST depression, chest pain, and as one of my colleagues likes to say, it was an underwear moment. And so, the challenge was, how do you deal with this? We tried aspirating thrombus with the guide catheter, which was ineffective. The thrombus was too large. We tried a new aspiration device, which was ineffective. And finally, what we were able to do is actually push that thrombus back into the circumflex with the guide catheter and then break it up with a balloon. And that was essentially what got us. And so that was kind of the aha moment. We all have experiences where, we really question what we're doing. Are we doing the right thing? And so this was an aha moment that maybe we needed more evidence for routine thrombectomy. There was a call for grants, I remember, pilot studies, and I proposed a pilot randomized trial. And this pilot randomized trial ended up getting published in New England as a full trial, the total trial, a randomized trial of prime PCI versus routine with manual thrombectomy versus not. And so this trial was, I think, one of the largest prime PCI trials ever performed. We randomized 10,732 patients with STEMI undergoing prime PCI to one of two strategies: routine upfront manual thrombectomy with the export catheter versus PCI alone with only bailout thrombectomy for specific criteria. So after you balloon, if you have persistent large thrombus with TIMI 001 flow or persistent large thrombus after stent deployment. The primary outcome was CV death, recurrent MI, cardiogenic shock, and class 4 heart failure at 108 days. And the primary safety outcome was stroke within 30 days. And what we found, in fact, there was no difference. To our surprise, that in fact, there was no difference in the primary outcome, 6.9 versus 7%, and no difference in terms of CV death, recurrent MI, cardiogenic shock, and class 4 heart failure. And I remember back at that time, Salim used to insist that you get paper printouts of all the data outputs, and you'd sit there looking at the data with a pencil. And I remember seeing a significant p-value in the outcomes, and I was like, finally, something. And what the significant p-value was, in fact, stroke. And I remember it kind of took my breath away. We saw a doubling in the risk of stroke within 30 days with thrombus aspiration. And this trial changed guidelines. This went from a class 2A recommendation to use routine thrombus aspiration to a class 3 recommendation, given the harm observed in terms of stroke. We then, we kind of scratched our heads and said, why was TAPAS different than total? Or was it just because we were 10 times larger? And in fact, when we put an individual patient meta-analysis with nearly 20,000 patients, we in fact saw no significant difference in terms of CV death. When we looked at the high thrombus burden group, that's really where the money is. If there's not a lot of thrombus, there's likely not a lot of benefit. What we observed was essentially there appeared to be a signal of benefit in terms of CV death at 30 days in those with high thrombus. But the paradox were that's the very group. Those with lots of thrombus are also the ones who were suffering strokes. And when you looked at that group out at 6 months or a year, the CV death curves came back together again. And it's likely that we were preventing distal embolization and improving angiographic outcomes, but unfortunately, with that current technology, we were unfortunately causing some strokes. And at the end of the day, it was a wash in terms of the benefit. And certainly, if you ask me, a stroke is probably one of the worst outcomes that you can have. So where do we go from here? I think clearly thrombus aspiration should not be done routinely, and it's a class 3 recommendation in the guidelines. It's important to remember that we shouldn't throw out the device. In the control arm, bailout thrombectomy was used in about somewhere in the range of 8 to 10% of patients. And so when you have large thrombus and you balloon it and there's still, you can't proceed, you've got TIMI 001 flow with a huge amount of thrombus. We've all been in that scenario. You need some sort of technology. And in fact, my experience, sometimes manual aspiration works, but many times it doesn't. And so we actually need new devices that are able to manage high thrombus burden. They need consistent suction, not just a syringe on the end. And they need to minimize the risk of thrombus embolization to the systemic circulation at stroke. And the question is, do we have such a device? I don't know. We've certainly got the new CAT-RX device on the shelf, and we've had some recent success with it. And I'm encouraging the company to pursue a Total 2 trial, where in fact you have a much improved device that perhaps can see a reduction in mortality, particularly if we can avoid the stroke signal seen in Total. So stay tuned. There may be future trials in this space. Next, I'm going to move on to complete revascularization in STEMI. And my colleague Shamir Mehta was the PI, and we had a significant Canadian contribution to this trial. So in patients with multivessel CAD, the question is, does complete revascularization improve outcomes compared to just culprit alone? And we randomized nearly 4,000 patients with complete revasc versus culprit only. And the follow-up was over 3 years. The co-primary outcomes were CV death or new MI, CV death, new MI, or ischemia-driven revasc. And I think one of the important things is this was primarily a primary PCI population. This was pretty much split between LAD and non-LAD lesions, and complete revascularization was achieved in the vast majority, 9%, with a residual syntax score of 0. The baseline syntax was only 16, and the non-culprit lesions syntax was only 4.5. So these were relatively straightforward lesions. For the most part, this wasn't complex disease that was being treated. And so complete revascularization led to a 26% reduction in the composite of CV death or new MI. And this is really one of the first PCI trials that showed preventative PCI, essentially prophylactic PCI, improved outcomes and particularly prevented MI over follow. Very, very exciting from a pathologic perspective. If you looked at the second co-primary outcome, CV death, new MI, or ischemia-driven revasc, there was a 50% reduction, number needed to treat of 13 patients. Again, a very effective intervention for these patients. When you looked at other outcomes, really a marked reduction in MI as well as ischemia-driven revasc, but there was no overall reduction in either CV death or all-cause death. You were really preventing MI. In terms of the type of MIs you prevented most likely non-STEMIs, and most commonly you prevented spontaneous MIs, type 1 MIs, rather than any other MIs. One of the questions is, do you need to do this in hospital, or can this be staged as an outpatient a few weeks later? And the answer is, it really doesn't matter, because most of the events related to the non-culprit are long-term events. If an event happens at a week, it's most likely related to the culprit, the stent that you initially placed. So there was really no interaction based on initial hospitalization, which is about on a median of 1 day, versus after hospital discharge, which is a median of 23 days. And it was similar for new CV death, new MI, or ischemia-driven revasc. One of the other questions were in terms of the predefined subgroups, LAD versus non-LAD, similar benefit. Lesion severity was a predictor of benefit, so that if you have a moderate lesion, there didn't appear to be as much benefit as if you had a severe lesion defined as 80% visual or greater than 60% core lab. And so the message here is it's really the severe lesions that is a benefit. If you're not sure there's a lesion there, you probably don't need to worry about it, at least from this analysis. And residual syntax, again, consistent findings. So in conclusion, the complete trial definitively showed in patients with STEMI and multivessel disease that routine complete revascularization reduced CV death or new MI by 26% and reduced the composite of CV death, new MI, and ischemia-driven revasc by about 50%, number needed to treat of 13. It doesn't matter whether you do it during your index hospitalization or hospital discharge, and there was no significant differences in other outcomes such as bleeding, stent thrombosis, acute kidney injury, or stroke. We're going to move on to a case, and this will highlight the need for future trials. This was a patient that I had when I was attending on CCU as well as interventional staff. So 51-year-old male, he's driving on a highway, and I don't know if people know the Hamilton, Toronto area, between Toronto and Hamilton. He's developed chest pain. He pulls over by the side of the highway, and he promptly has a cardiac arrest. Amazingly, a car pulls over and does bystander CPR. They call 911. An ambulance arrives. He's in ventricular fibrillation. He gets shocked. The pre-hospital ECG shows an inferior ST elevation MI. I get called as the interventionalist. What we find is that, in fact, the RCA is, by the time he gets to the lab, is open, but has plaque rupture, 99%, is treated with PCI. He has moderate Cs with plaques in the circumflex and distal LAD. He, in fact, makes a full neurologic recovery, and he's discharged home on aspirin, ticagrelor-statin, ACE inhibitor, beta blocker. I see him in follow-up. I'm also the CCU cardiologist, and his family doctor had ordered some blood work. His LDL came back at 1.2. That seemed appropriate. His CRP came back as high, and I didn't really know what to do with the CRP. And what did I do then? I simply ignored it and continued on his medical therapy. 18 months later, he presents with a non-STEMI, having ongoing chest pain for about 12 hours. He's brought to the cath lab. He has an occluded left circumflex. His EF is 30% and is treated with PCI. And his course is complicated by congestive heart failure and pericarditis. The concept here is coronary disease is a chronic disease with acute exacerbations, and could we have prevented this progression in this gentleman in his early 50s? And really, one of the targets we're looking at is inflammation in heart disease. This was in 2006. The cover of Nature was CRP, and it really hypothesized that if we could treat inflammation, we could cure a coronary artery disease. And of course, that hasn't been the case, and we've had a number of failures. And this is a slide I often show that in this space, we have failed multiple times to find a target for inflammation to treat coronary artery disease. And it's only recently that we've started to see some success. We certainly know that steroids are not probably the right therapy in terms of acute myocardial infarction. There is some data supporting that, in fact, steroids can increase the incidence of free wall rupture by impairing infarct healing. And so, this is one of the important things that, in fact, some therapies can be harmful, not necessarily beneficial. Paul Ridker led the CERT trial that looked at methotrexate in patients with coronary artery disease and found no difference in the incidence of MACE with the addition of methotrexate compared to placebo in addition to standard therapy. What about success? The first trial that showed that an anti-inflammatory improved outcomes in patients with coronary artery disease was the CANTOS trial, randomized 17,000 patients post-MI with a persistent elevation in hs-CRP to an IL-1 inhibitor, canakinumab. And what it showed was for the first time that there was a modest but significant reduction, 15% reduction in CV death MI stroke with an anti-inflammatory drug, canakinumab, at higher doses in comparison to placebo. And when you looked at unstable angina requiring revasc, that effect got slightly larger. When you looked at the individual outcomes, there seems to be larger reductions in terms of urgent revasc. They seem to prevent cardiac arrest. So really, really interesting, though we didn't understand why this was happening. Was it affecting plaque morphology? Why was it affecting cardiac arrest? So it led to many more questions into why we saw that. And then why didn't you see a reduction in mortality if you were preventing all these important outcomes? And this may be an understanding of why you didn't prevent mortality, is that the side effect of an anti-inflammatory drug may be infection. And there was a significant increase in the risk of fatal infection, about a doubling in the risk of fatal infection. So while an antiplatelet may cause bleeding, an anti-inflammatory may cause infection. The other very intriguing thing was at the highest doses of canakinumab, there saw a 50% reduction in the incidence of fatal malignancy. And you may ask, well, why would an anti-inflammatory drug reduce the incidence of fatal malignancy? And Paul Ridker hypothesized that, in fact, chronic inflammation causes a lot of cell turnover, may lead to genetic mutations, which may lead to cancer and malignancy, and that by preventing chronic inflammation or reducing it, perhaps it's not only good for the heart, but may also be good in terms of preventing fatal malignancy. This is a really interesting hypothesis, and maybe as important, in terms of future patient care, in terms of anti-inflammatory drugs. Not surprisingly, there was a marked reduction in gout with the addition of canakinumab. So this is a diagram from Paul Ridker showing the effect of canakinumab, IL-1 beta, and IL-6. And it's really important that all anti-inflammatory drugs are not created equal. And it's likely this particular pathway may be important for the pathogenesis of coronary artery disease. And that we have a very inexpensive drug canakinumab is a sub-Q drug that costs thousands of dollars a year. Colchicine is an oral drug that costs pennies a day, that in fact achieves some of the benefits in terms of the effect on IL-1 beta, but furthermore works upstream and actually may have even greater benefits in terms of effects on coronary artery disease. So very, very exciting. There's one trial in ST elevation MI that took patients on the cath lab table, randomized them to a higher dose colchicine for 9 days versus control, and found about a third reduction in infarct size. So on the left-hand panel is area under the curve for CKMB. Right-hand panel is cardiac MRI. So there's a hypothesis that early administration of colchicine in the midst of an infarct may reduce the infarct size. Again, very exciting. Of course, we're a little worried given steroids and the risk of frual rupture. So certainly that safety is important. Now, the first large clinical trial was from Jean-Claude Tardif, really a landmark trial in terms of colchicine called the COLCOT trial. It took patients within 30 days post-MI and it treated colchicine 0.5 milligrams daily versus placebo. And the primary outcome was CV death, cardiac arrest, stroke, or urgent hospitalization for angina recurrent coronary revasc. And what it showed was that there was a 23% reduction in this primary outcome. There was about a 50% reduction in the outcome of urgent hospitalization for angina recurrent revasc, which is interesting, but no effect on MI. So that kind of left some people, and no effect on CV death, scratching their heads. Why are you preventing urgent hospitalization but not preventing MI in the era of high sensitivity troponin? Is it preventing restenosis? What's happening here? And of course, colchicine has been tested in the past as a therapy for restenosis. This is the importance of placebo. And when you look at gastrointestinal adverse events, we know colchicine is associated with diarrhea. But what was interesting is, in fact, the rate of diarrhea on placebo was pretty high as well, 9.7 versus 8.9%, really not any different. The incidence of nausea was a little higher, the difference of flatulence was a little higher. Importantly, pneumonia was doubled with colchicine. So again, a similar signal to what we saw with canakinumab, you can increase the risk of infection with an anti-inflammatory. The next trial was the LIDOCO-2 trial, and this was in patients with stable CAD. This was performed by colleagues in Australia as well as in the Netherlands, and took patients with a 30-day run-in of colchicine, so to ensure that they could tolerate it. And I think the importance of the run-in is that you're going to make it, if you're only going to have a population that is tolerating your study drug, you're going to make it more likely that you have a positive result in terms of trial methodology. So I think from that perspective, brilliant to do that, and probably for any stable populations, it's a worthwhile thing to do for colchicine. And what they found was a nearly 30% reduction in their primary outcome of CV death, MI, ischemic stroke, or ischemia-driven revasc. And again, very, very exciting. Effect size is slightly larger than the COLCOT trial, likely related to the run-in period. What was also interesting is that there was this signal of non-CV death, 1.9 versus 1.3%, p-value of 0.06. And it was interesting, the New England was really interested in this non-CV death signal. It was interesting that it could not be explained by hospitalization for pneumonia or hospitalization for GI reasons. So, it was very quickly after the trial, I received, emails and texts from Mark Nidoff, one of the co-PIs from Australia, asking what my opinion of this was. They actually asked if our DSMB can review our data and see if we were seeing similar findings. And our DSMB reviewed this data as well as our own data and recommended that we continue and not unblind in any specific way. And what we did is, in fact, with the LIDOCO-2 investigators, we actually did a updated meta-analysis of colchicine. And it was interesting because there was an Australian trial called the COPS trial in ACS that had come out at the same time that also showed an excess of non-CV mortality, 5 versus 0. So we had 2 trials showing this signal that perhaps there may be some downside to colchicine. And you can see that there's nearly 10,000 patients recruited here in these randomized trials. And there is this same signal, p-value of 0.06, odds ratio, a relative risk of 1.38 for non-CV mortality. And the real question is this a real finding? Are we causing more non-CV deaths and preventing MIs or preventing ischemia-driven revasc, or is this a chance finding? And I sat down and chatted with Salim Yusuf, and he looked at me and he says, it might be real, it might not be. And he told me about the stories of the statin stories where there was concerns about malignancy and non-CV death in some of the early trials. He said it may be a similar story or it may be real. You need to finish your trial and find out. Now, colchicine is for the first time now mentioned in the ESC guidelines, and it's really the first time that colchicine has been mentioned. I think that's a testament to the colchicine trialists that have both Colcott and Ladoco true, and it provides a class 2B recommendation when other risk factors are insufficiently controlled or recurrent events. And it's interesting when you read the text, they state that the role of colchicine has yet to be established in clinical practice pending further trials. And I think this is may have disappointed some, but really argues that further trials are needed. And we're particularly poised with the CLEAR OASIS 9 trial to answer this question as the largest colchicine trial ever performed. And likely to finish recruitment in the next 6 to 9 months. So what is the design? This is a CHR-funded trial. We will randomize 7,000 patients, and we've randomized close to 5,500 patients already internationally. And it's a 2x2 factorial design. Patients are randomized as inpatients after their PCI for MI to either colchicine or placebo or spironolactone versus placebo. We have an embedded stent registry, which is completed with partnership with Boston Scientific. And the primary outcome for colchicine is CV death, recurrent MI, and stroke, and spironolactone is CV death or new or worsening heart failure. So, we, in terms of anti-inflammatory therapies, we know that methotrexate is not beneficial. Canakinumab has modest benefits, but very expensive. And colchicine is clearly associated with benefits. However, the non-CV mortality is an open question. Okay, in terms of spironolactone post-STEMI, why pursue this question? And if you measure the aldosterone level in the blood in patients with acute myocardial infarction, the higher the aldosterone level, the higher the mortality. And the question, of course, is this cause or is this simply a marker of risk? The chicken versus the egg hypothesis, and we simply don't know. Now, 20 years ago, Bertram Pitt and colleagues published the ROUSE trial, which showed that in patients with chronic heart failure, spironolactone compared to standard therapy reduced mortality by 30%. And this was a major breakthrough. And it's interesting, I think Bertram Pitt is, I think, in his late 80s now. And it's quite amazing that he is continuing to present and publish in New England. In fact, sits on our steering committee and has really been very valuable as providing advice for our trial. In post-MI patients with heart failure, the EPHESIS trial tested eplerenone, so another mineralocorticoid antagonist. So these are patients with the EF 40% with RALS or with diabetes, and patients were stabilized 3 to 14 days, randomized nearly 7,000 patients, and showed a 15% reduction in mortality. Now, this is data from the US NCDR registry looking at more than 200,000 patients with acute MI. And what they found was only 10% were eligible for EPHESIS. So we're really targeting that other 90% of patients. That's the evidence gap that we have in the CLEAR OASIS 9 trial. Of those 10% that were eligible for the EPHESIS trial, only 15% got the drug. So there's both a evidence gap as well as a knowledge translation gap. People ask, well, why are you bothering treating or testing this hypothesis? And this is analogous to the iteration of evidence in terms of ACE inhibitors in heart failure. In symptomatic patients, the SOLVE treatment trial showed that ACE inhibitors were beneficial. And asymptomatic LV dysfunction, the SOLVE prevention trial showed that ACE inhibitors were beneficial. And this is analogous to the SOLVE prevention trial for the CLEAR OASIS 9 trial for spironolactone. The final trial, this was led by Gilles Monalesco in France, took patients with both ST elevation and non-ST elevation MI in the first 72 hours. They randomized them to IV aldosterone antagonist ketorolac, followed by spironolactone, and randomized 1,600 patients. And the primary outcome was death, resuscitated cardiac death, VFVT, indication for ICD or heart failure. And what it found, in fact, there was no benefit to routine aldosterone antagonism in this broad population. In the subgroup of STEMI, there did appear benefit, but in fact, Gilles Monalesco is our national lead in France and really believes in this question. One of the important things, is there any downside to spironolactone? And this is data from Dave Urlink in Ontario, published back in New England in 2004. And when the RAILS trial was released, there was a marked increase in the prescriptions for spironolactone. And concurrent with this, the rate of admission to hospital for hyperkalemia more than doubled as a result of broad use of spironolactone. And what was also interesting, the rate of hospital death from hyperkalemia also markedly rose. So I think one of the important things is spironolactone is not risk-free. Particularly hyperkalemia can be a serious issue and can lead to mortality. So, I asked Bertram Pitt in terms of, you have a patient with an EF of 35 to 40% on cath, who doesn't meet FSS criteria, doesn't have diabetes, asymptomatic, and he harkened back to some of this data that we really need to test this and make sure that it is beneficial before using it in every single patient. Based on the existing data, we believe a large simple trial is needed for routine aldosterone antagonism post-MI, similar to ACE inhibitors. And the hyperkalemia associated with spironolactone is not without risks. So in conclusion, inflammation is likely important in CAD, and this is likely the next breakthrough, similar to statins, antiplatelet therapy for the treatment of coronary artery disease. The CLEAR trial will definitively examine if colchicine and spironolactone are beneficial in acute MI. This is not where, actually, we've gone beyond STEMI. We also include non-STEMI. As a interventional and EP colleagues, occupational radiation exposure is probably one of the most important issues, not only for your back and the lead, but also for in terms of cancer. And this can be reduced by simple measures such as putting lead on the belly of a patient. Third, routine thrombus aspiration was not beneficial in STEMI, and really you need more of a targeted approach, and we need better technology to treat these patients. Finally, complete revascularization is beneficial in STEMI, and this is now a class 1 indication of the guidelines. And thank you.
Thanks very much, Sanjit. That was an excellent presentation. I've not seen any questions in the Q&A yet. Maybe it just takes a bit of time for what you've spoken about to sink in. But one thing that you've drawn attention to me, as always, is that as interventionists, we often jump on the next new bandwagon very quickly with small trials. And it's often a bit more cautious just to wait for large trials to confirm the results. I might just start off then simply with your first trial, the radiation protection, which is often one of my bugbears in the cath lab. I have always advocated putting lead under the patient rather than over the belly, because there's some data suggests that by putting it over the belly, then you're resulting in the scatter into the patient's body. So under the patient is a little bit better, but there's an inconvenience of dragging it out if you were to convert, which in my hands is usually quite low anyway. But there seems to be a resistance about, just an additional thing. It's always just one additional thing and one extra thing to do in the lab. But this is for our benefit. And I think you've again highlighted just simple things, which I really like, simple things that make big differences.
Yeah, I think that's an excellent point, that simple things can make differences. I think I think from a knowledge translation point of view, getting the nurses to understand that this is as important for them as it is for us, right? That they're scrubbing for all these procedures, and their risk of malignancy may be increased as well, so that it is worth the time and effort to do that. The second issue in terms of putting the lead under versus over, I think is really intriguing. And there, you're right, there is a concern that perhaps you may increase scatter to the patient. The one question I would have is, it'd be interesting to do a follow-up trial to look at the effect of putting lead under versus over for the patient as well as for the operator. Because, one of the interesting things, we were testing dosimeters, and I would stand beside the beam and I would get virtually no scatter with the real-time dosimeter. And then what we did was we put like a dummy, one of the physics, our physicists had a dummy that's supposed to recreate scatter, and you put the dummy in there, and then all of a sudden you're getting hosts of radiation. So so the patient, one of the concerns is if it's underneath the patient and if the patient is scattering all that radiation, it may be substantially less effective. I don't know. But I think it's a worthwhile thing to test, and probably can be done in a few hundred patients fairly easily. Really simple fellow randomized lead trial.
I agree. I'll just follow up that very quickly. We have an advantage of having the dose aware on the Philips system, which gives us real-time exposure. And if the fellows position the lead shields and inappropriately, the second operator gets more radiation than the first. So I think that's always been my interest. I'm often the second operator now rather than the first. So I try and hide behind big fellows, but that's sometimes impossible. I see Peter has his hands up, so I'll let Peter ask the question.
Oh, great. Yeah. So Sanjit, it's a fantastic overview. It's really cover a lot of very exciting grants. And of course, inflammation is very much an area that I'm interested in as well. So it's fantastic you're doing this very important trial. And, the problem with inflammation is that, inflammation or the immune system is created, for one set of purpose, right? Just when it really gets activated excessively or for a prolonged period of time. And that's when it really actually comes back to haunt us in a way. And so, but very intriguing information from what you presented, and kind of a couple follow-up questions. One was the potential concern, in terms of whether the harm signal is real or not. And so I was wondering whether people have looked at the potential causes of death, because in the early days with statin, some of these turned out to be suicides, some of these really kind of random distribution of things that ultimately did not have a biological, rationale. So that's one side of the question. And the other side of the question was that when folks look at, for example, the CANTOS trial, or look at the other aspects when there was CRP measurements, for example, if you have the dose, or if you have the patient who was elevated CRP, or if there is at least the dose is able to lower the CRP, that appears to be beneficial. And so so I was trying to figure out whether dose, certainly in CANTOS, there appears to be a dose-related, effect to a certain extent. And so I was wondering whether, in the colchicine trial, whether that was seen or not. So the question on what are the nature of the death that was observed, and whether dose is at least, have any relevance in terms of outcome. Yeah.
Yeah, that's I have seen a few case summaries of some of the death reports from these trials, and it's a mix of different things. It's not predominantly car accidents or trauma, but there is a mix of different mortality, and we couldn't necessarily make heads or tails of it in terms of, clearly in cold cut there was an excess of pneumonia, but so I think we're not really sure in terms of that aspect. And I think in terms of the amount of data collection has been variable in some of the different trials in terms of what was collected. The second question, what was your second question about?
In terms of, is there a dose?
Yes.
And whether sort of that may or may not influence outcome. Yeah.
Yeah, it's a question that I've asked myself for the last 5 years. Are we using the right dose of the drug, right? And I think too much of a dose, you're going to cause problems. Too little, it's not going to work. So I think it's a really important question. the first question is, does colchicine reduce CRP? And there is, in fact, a conflicting data. I think most of the data suggests that it has a modest effect on CRP. There was a sub-analysis from the Colcott trial that showed no effect on CRP, and there's certainly a small ACS trial showing no effect on CRP. So it may not affect, it may or may not affect CRP, and which is interesting because Colcott saw a benefit despite that. The second question is, does dose matter? Should you use a pericarditis regimen, in terms of 0.5 milligrams twice daily, or should you use the low dose regimen that was used in these trials? And would you get greater benefit if you use 0.5 milligrams twice daily? And I can tell you, Peter, this is an issue that I wrestle with. And in fact, initially when we started CLEAR, we were using a higher dose regimen in the first few thousand patients. And what we observed was tolerability goes down. And I think one of the issues is that if you go from, a rate of, 5% of diarrhea or 7% of diarrhea to 15%, it really reduces, in a long-term treatment trial, it really affects. And so, and the other issue is that the workload for study nurses to get patient on study drug on a lower dose, because we had basically a protocol that said if you got diarrhea, stop the drug, wait for it to wear off, then go on a lower dose, which is the right thing to do. But it is inevitably very, very difficult to convince these patients who had watery diarrhea to go back on study drug. But we'll have probably at least 2,000 patients out of our 7,000, or at least 1,500, where we've looked at higher doses. And we have a large number of CRPs within our database, both regular CRP and HS-CRP, so we'll be able to see that. And we also have a specific biomarker sub-study led by Benita Shah, funded by the NIH, where we will have detailed biomarkers, genetics, in hopefully about 300 patients. Though the pandemic has played havoc with the biomarker sub-study because it required patients to come back to hospital, get their blood spun, and so on. So the biomarker sub-study is behind in terms of recruitment because of the switch to virtual care and couriering drug to a patient's house and doing the telephone follow-up.
Great. Yeah, so very thoughtful, and look forward to the results. Yeah, very, very exciting. Yeah. Fantastic.
Can I just remind people to put their questions in the Q&A rather than the chat? Then Sanjit can answer them.
There are actually a few on the chat line.
Yes, I'm going to read them for Sanjit. So Girish Nair, firstly, excellent talk. Does lead on the belly of the patient increase radiation exposure to the patient? I think we answered that. Do we use rad pads? We reserve it for CTOs just to protect a little bit more, mainly because of the cost. Do you have anything to add to that, Sanjit?
Yeah, one of the things I would say about the rad pads is, I chatted with our radiation physicist, who is this, guy probably in his 60s, and asked him what his opinion of the rad pad is. And he looked at me and said, it's pure physics. Nothing blocks radiation better than lead does. So there's no question that the rad pad will have some effect, but lead will always be better, but it'll be heavier. It'll be a bit more pain in the ass, but will save the hospital a ton of money. Yep. So it's really your choice what you want to use. And when you talk to your cath lab manager, your EP manager, they're like buying a piece of lead for a couple $100 that will last years versus rad pads, which I think are about $20 a piece, and you may need multiple per case. So for them, it's a no-brainer.
And there's another question from Girish. Is there a relationship between respiratory infections precipitating plaque rupture that could explain the rise of pneumonia-related mortality in your colchicine trials?
Yeah, that is an interesting question. And, the parallel I will say is that, there was the influenza vaccination trial, the IAMI trial, which, I was very surprised that it was positive. And they stopped the trial early because, so this took patients with acute MI, essentially in the CCU, they randomized them to vaccinating for influenza versus not. Ole Frobert was the PI and is a friend of mine. And I told him that it's going to be tough to do in Canada because he had asked me to participate. And I think they were paying $100 per patient. But they showed a significant reduction in mortality and a composite outcome, CV death MI. So, there is a real hypothesis there that, perhaps, some infections can be quite bad. And, are they type 2 MIs? Do they cause type 1 MIs? I don't think we know the answer to. All we know that it's bad, and certainly influenza type infections, if you prevent, are really good. And it's interesting, we have not gone to vaccinating for influenza in the CCU. I'd be interested to know if you did, but it's one of these low cost interventions that, especially during influenza season, probably is a reasonable thing to do given all the expensive therapies that we offer.
Yep. I'm not sure whether your previous fellow suffered PTSD from you, Sanjit, because he's afraid of putting his hand up. So Zishan is asking, where do you see neprilysin inhibitors fitting to this narrative?
Yeah, the unfortunately that trial was negative. It did not show significant benefit for neprilysin inhibitors in patients post-MI with heart failure and LV dysfunction. I'd be interested in what Peter Liu's opinion is as a heart failure doctor, because there was a modest effect. If you changed your analysis and looked at cumulative events, the trial was positive, and so it seemed to prevent recurrent events over time, not just the time to first event. And I do wonder where if you have some of your worst patients who you're really suspecting that LV, they're a late presenter, their EF is 20%, they're in heart failure, their prognosis is bad, whether neprilysin inhibitor is a better approach than ACE inhibitor. Peter? You're muted, Peter.
Apologies. Yeah. Oh, absolutely. Yeah. So I think your thinking is exactly what we think as well. And we had Mark Pfeffer, with us, kind of do a deeper dive on the data, exactly as you mentioned. And so secondary analysis does actually show that, particularly for the higher risk, for the longer follow-up, you do actually see significant separation. And keep in mind that, this is a comparison, again, similar to the other studies with valsartan, comparing to an active comparator rather than, the more traditional placebo. And so I think for the higher risk patients, with the worse ventricular function, certainly with late presentation or less effective rescue in that type of setting, I do think that the data does support more, potentially more benefit in those type of patients. For the patient who's actually otherwise doing well, who's stable, who's got, great timing and the procedure effect, it probably doesn't make that much difference. Yeah, I fully, agree with your approach. Yeah, so thanks for that thoughtful response. Yeah.
We do have one question from one of our residents. Simon, you have your hand up. Can you unmute yourself? You're still muted, Simon.
Sorry, no question.
Oh, no question. Okay.
There's a question from David Burney. Why do you think COMPLETE was positive and COURAGE was negative? More extensive disease, more left main. And, it is, and the more common question we get is, why was COMPLETE positive and ischemia negative, right? And Shamir comes up to me in the cath lab probably once a month and says, we should do ischemia too. I look at him and say, okay, you write the protocol first. I think if you looked at really spontaneous MIs, the effect is similar. That there is some sort of effect that PCI seems to prevent spontaneous MIs. In ischemia, there was a penalty in terms of periprocedural MIs, so that the effect was neutral. So the issue is now this whole concept of periprocedural versus spontaneous MIs. And I think the other issue is in COMPLETE. You've had a STEMI yesterday. You do a PCI. you're not going to see a paraprocedural MI unless it's catastrophic. So, you know, and so paraprocedural MIs were essentially functionally taken out by the population. I think those are two possibilities. I think the third option is, are they different patients, right? Are ACS STEMI patients, do they have panvascular inflammation? Do they, are their plaques much more likely to rupture over the long term? And is PCR particularly more beneficial in this population? So, all three of those are possibilities. But certainly there are people who want to do further studies. And I know in Ottawa, you guys routinely measure biomarkers post-procedures. Isn't that right, Young and Derek? But we don't.
Some of us do, yeah.
So oftentimes patients who have a bit of chest pain post-procedure, but a few hours later is fine, go home same day, don't get biomarkers at our place. And, the issue is, that versus a spontaneous MI 2 or 3 years down the line, which is more important.
I'm just reading through the comments just to make sure that we've not missed anything. So Dr. Froschel has reminded everyone that, yep, I agree. And I think if you also mentioned it, in the setting of an ACS, there is no such thing as stable coronary artery disease because of that pan vasculitis that you've mentioned. And I think there's evidence from NIRS, so near-infrared catheters, that you see, red spots, hot spots in the same artery in different areas and even in different vessels. About what to do with those, I think requires further research. I don't see any further questions. Are there any closing remarks that you'd like to make, Sanjit, in the last minute or so?
I'd like to thank the Anne Young and Derek and the CCU and interventional team for participating in the CLEAR OASIS 9 trial. We really hope that we won't see an increase in non-CV death related to colchicine. And we really hope that colchicine will become the next statin for coronary disease. And we hope that, in fact, spironolactone will become the next ACE inhibitors. And I've been following the finerenone data fairly carefully. And it's interesting that finerenone may be, an important drug, particularly preventing CKD. So that's a really interesting hypothesis, that it may prevent CKD progression as well as ischemic events and heart failure. So really, really exciting, and whether spironolactone can do the same.
Okay, I mean, with that, we come exactly at 8:30, and I think you do have a session with our residents, Sanjit, just for half an hour, just to get some inspiration from you.
Okay, wonderful.
Thank you, everyone.